car accident. It's worse from a medical standpoint if your 42-year-old mother died of a heart attack, because girls shouldn't have heart attacks when they're 42. So that's the kind of stuff that you look at in terms of gleaning a history for longevity of your patient, okay? The other thing he asked about is intermittent claudication. So claudication happens for two reasons. Claudication is I walk and my legs hurt, so I got to stop. And then they feel better, so then I can walk again, okay? Happens for two reasons neurologically. Now everybody will notice it when you go to Publix and everybody grabs a shopping cart and they do this, because they're opening up the holes where the nerve roots pass out and they're getting better nerve transmission to their legs. So when they stand up, their legs hurt. When they lean over, their legs feel better. It's really sad. My father started to do it. I'm like, MRI time. But that's neurological claudication, neurogenic claudication, I should say. And then there's vascular claudication. So everybody yesterday was auscultating the iliac arteries, femoral arteries. When you start to hear the bruit, that's bad, right? Because that's indicative of a narrowing of the vessel. But what happens clinically to the patient is they start to develop vascular claudication. So I walk and my legs aren't getting blood flow. Well, that really hurts. So I'm going to stop. And the muscles are going to kind of relax around those arteries. Better blood flow is going to happen, and then I can walk again. So that's intermittent claudication. So it happens either from a neurological standpoint or from a vascular standpoint, okay? Vascular is worse, like, what's the word? It's the worst predictor of life expectancy, I guess. This is, you know, a lot of people get neurogenic claudication. They just lean forward on a shopping cart. Yeah. Or they get surgery, whatever. Okay, so when we talk about the motor pathways, I'll quickly go through this because it's been on other slides. But again, we talk about the corticospinal tract. So again, voluntary skilled motion of all of our extremities, those transmitting fibers down. Once we've relayed up in the somatosensory cortex, we've relayed to the motor cortex and we're transmitting south. Basal ganglia is for the course control, and the cerebellum is more so that postural sense, equilibrium, kind of where we are in space, okay, balance and coordination. Sensory pathways, obviously we're going north, we're going superior. So we have the ventral and the lateral spinothalamic tracts. They're going to help carry all those impulses up, so light touch sensation, pain temperature sense. Our posterior columns are going to be your vibration sense. So when we get down to next week talking about using a tuning fork on a lower extremity, for example, for somebody with diabetes, this is why they don't have great sensory input, because those sensory fibers down in the big piggy toe are kaput, okay? Passive motion, joint sense, again, so all that is rallied up, and that's why we kind of know with regards to our cerebellum vision and our position sense of our joints where we are in space, as well as two-point discrimination. So two-point discrimination is if I stick you with 2 needles, can you tell that I'm sticking you with 2 needles and not just with 1, okay? Maybe we'll practice on each other with that. All right, so again, that just shows you your ascending sensory fibers always being your input, and essentially your efferent, your descending fibers being your motor output. Oh, I didn't know I did that. Okay, neurological exam. So when we talk about neurological exam, we're looking at mental status, cranial nerves. Those are primarily the things we're going to talk about today. Motor function, reflexes, sensory function, as well as cerebellar function. That stuff we'll cover next week. So your mental status is a ton of stuff, right? So right away, it's your level of consciousness. How alert are you? Are you awake this morning? That type of thing. Attention, orientation, your affect and mood, your speech, your language, your insight, kind of how you would do in terms of judgment of certain issues, your thought process, your thought content, which sometimes is not the cleanest, perceptions, your higher cognitive function, okay, in terms of memory, vocabulary, calculating skills, those types of things. We'll talk about all of those today. So we talk about appearance and behavior, and we talked about this in history. There's so much that you can glean by how the patient walks in and sits down and what they look like. Is the patient disheveled? Is the patient like my Uncle Johnny, God rest his soul, who did not wear shoes to Thanksgiving dinner, even though he walked 2 blocks in his socks, okay? That tells you a lot. Are they coming in? It's one thing, you know, not to be crude, but it's one thing if an 80-year-old man forgets to zip his fly, because that happens, okay? But is a 25-year-old guy forgetting to zip his fly? That's a problem, because that should be automatic for them. It's a little bit more acceptable in an 80-year-old who may have forgotten to do that. But there's simple little things that you're looking at. Are their shirt halfway untucked? Are they kind of walking in with their belt undone? Do they look like they haven't showered in 3 days because they haven't showered in 3 days? Their hair's not combed. All of those grooming type of easy issues you look at. You look at their facial expression. Are they looking at you like they're looking right through you? Like you could drop off the face of the earth and they wouldn't even care? They should be engaged, okay? They should be talking about you. And all of that stuff you're getting just from the fact that you walked into the room, or they walked into the room and they sat down, okay? You're getting a lot of that information just from the history taking. So their manner, their affect, how are they relating to other people and other things? How have they, before you even walked into the room at your doctor's office, what did the nurse tell you about how they treated the front staff? Were they rude? Were they belligerent? And have they always been nice? It's one thing if they're coming in and that's your first impression of somebody. But if they've always been nice, kind, compassionate, and all of a sudden they're coming in and they're rude and belligerent, that's a problem. If they've always looked like they're put together and all of a sudden they're coming in disheveled, that's a problem. Something happened, okay? When we talk about level of consciousness, so is the patient awake or alert? This scale you primarily use more so in the hospital when we talk about coma. So coma is basically you have to apply repeated painful stimuli, and even then you might not get the patient to wake up. Stupor, basically you have to pinch them. You got to put a pen to their nail bed and really push pretty hard. Sternal rub, although I wouldn't get to sternal rub too often. Really disgusting story. I didn't do it. My boss told me about it from when he was in residency. Sometimes one of the painful stimuli they do is they actually twist the nipple. Except when you twist it too much, it necroses and it falls off. So don't do that. Word to the wise. Are they just lethargic? Do you have to speak to them in a loud voice? That's different than somebody who has truly a structural hearing issue, which we'll talk about today. But somebody that you have to basically, repeatedly yell at to get them to wake up. So is it somebody also who just tends to lose track of things? Kind of you always have to redirect them to why we're here, what we're talking about? Or is it somebody who's fluidly staying with the conversation and responding to you kind of in an appropriate timing, okay, in terms of answering and asking questions? So their posture, this is somebody who lays in bed, or do they tend to want to pace? You have some of those patients that are like this, and you're just like, can you sit down? And they won't. They just kind of want to pace. They're nervous, they're anxious. They might be nervous and anxious from a personality disorder, but they might be nervous and anxious from an organic problem as well. So again, you want to know their body posture. Are certain parts of their body immobile, and is that different than what they've been in the past? For your patient who had polio when they were 6 years old, and they've always had maybe atrophy to a lower extremity and always kind of had a difference of gait, that's nothing new. That's how they've always been. Versus somebody who now kind of has a little bit of a foot drop. They're slapping their foot when they walk in, and you notice that difference in the sound. That was never there before. Automatically, you're jumping ahead a little bit to clinical exam in terms of motor function, but that's kind of your first impression, and you haven't even said good morning, okay? Their facial expressions, so again, they should be normal. They should smile appropriately. They should laugh appropriately, cry appropriately, all that kind of good stuff. There are the patients who truly are, this is where the frontal lobe-ish thing comes in. They laugh when they should cry, and vice versa. They cry when everybody else is laughing in the room. Their affect, their facial expression, how they respond to you doesn't fit the situation. So you have to kind of look at the clinical situation and make sure it's appropriate. When we talk about affect, so affect is something that I always think a lot about when I think about Parkinson's disease, because some people will just have a flat affect. You could tell them their mother died, and they would just be like, okay. You could tell them, you just won the lottery. Okay. I mean, that's a flat affect. They don't even care. Nothing phases them. And it's not the person who is just, what's the word? Like, reserved. Okay? It's not the person who's reserved or just in control of their emotions. This is somebody who truly, this is abnormal. Okay? It should evoke some emotion, and it's not evoking the proper emotion. Does it seem to be appropriate for extreme situations? And note the patient's openness, approachability. Is it somebody that just doesn't want to even tell you why they came into the office today? Which, of course, me being sarcastic says, then, why'd you come into the office today? Why did you make the appointment? What brought you in? And that they're not really opening up to you and giving you that information. Emotional responses again, so how are you feeling about that? If you've just told them a horrible diagnosis and they don't respond appropriately, you need to ask. You need to question that further, because if you're just told them, unfortunately the pathology was positive and you might have cancer, you have cancer, for example. And they're like, oh, okay. Well, if somebody wasn't responding to that diagnosis appropriate for me, my first response would be like, they already have metastatic disease and I already need to look at the head, because that should have evoked an appropriate response. Okay, that's not somebody who's just that much in control of their faculties that they don't get upset. When we talk about mood versus affect, so mood is to affect as climate is to weather. So your mood is typically pretty stable, right? People live in a temperate climate, they live in a wet climate, talks in generality. Whereas affect is more so like weather, it can typically change very rapidly. So you also want to talk about, look to relatives, look to friends, especially if somebody's come in with them today. Hey, have they always been like this? Is this something that's different or new? Again, this is almost before you're even really moving into the clinical exam. You're still really just taking a history, and you can start gleaning a lot of this information from them. When we talk about speech, we look at the quality of the speech, the rate of their speech. Don't anybody judge me on the rate of my speech. The loudness, their fluency, how appropriate is their verbiage? Is it coming out in a normal cadence, okay, or is it halting? Like I went to, that's different than your normal fluency that you should have in a conversation. So again, you want to look for hesitancies and gaps. You want to look for things that would be inappropriate in terms of fluctuation of tone of voice. Circumlocutions are those things that are like, I use that thing, that thing you used to write. Or, that thing that I take when I go visit my brother, it goes up in the air. Okay, so they can't say airplane, they can't say pen, but they can talk their way all around it. Versus somebody who paraphrases. So that can be somebody who says, I write with the den. Like they say den instead of pen. I write with the bar. They might write at the bar, which that's a whole different problem. But they don't know the proper word to say. They know what they mean, but they're just not getting it out appropriately. And if the patient's speech lacks any type of fluency, again, then we're looking for further testing, because then we're looking at primarily the temporal lobe and frontal lobe in terms of not only the input of speech, but the relaying out of speech, okay? So we test for aphasia, so we test word comprehension. So typically you ask them to do a couple stages of exercises. Take this piece of paper, fold it, put it on the ground. They need to follow commands. They need to be able to input the appropriate auditory stimuli. You ask them to repeat simple phrases. We always used to use no ifs, ands, or buts, and we still do. When you look at a stroke scale, there's other words that they tell you to use, like mama, tip top, 50-50, thanks, huckleberry. Those are the ones on the NIH stroke score. But you'll tell them to say no ifs, ands, or buts. One that I always used to tell patients to say, my first boss taught this to me, was Methodist Episcopal. It's hard to say, right? So you get my patients and they say, but I'm Baptist. That's easy to say, okay? You can't do the one word religions. You got to do the multi. So Methodist Episcopal is typically difficult to say and people stumble over it. And so that's why it's easy to figure out a little bit more complexity to their speech. Can you say no ifs, ands, or buts? No, say Methodist Episcopal. And most of them kind of stumble through that one. Naming of objects, so you'll give them, this is a pen, this is a phone, this is a piece of paper, and then typically you want them to name it back to you, and then typically a little bit later you're going to ask them, what were those three objects again? A pen, a phone, a piece of paper. So that also helps you with immediate recall of verbiage. So reading comprehension and writing, so sometimes you'll have them, sometimes on the writing you can even just see how they wrote their name, how they wrote their date of birth, okay? Because again, a lot of our writing goes to our motor function, right? Remember some of those motor function issues like Parkinson's disease, like MS, eventually the handwriting gets horrible because it gets so tiny. So a lot of that times you can see that even just on the paperwork they've completed. This is essentially the mini mental status exam so that you can do, and so basically we talked about this in history taking also, but it goes with the recall, registration. Again, ask them to name three objects. Typically name a pencil and a watch. So you just hold up your wrist, what is this? They need to tell you that it's a watch type of thing. So we talk about dysarthria. So dysarthria is basically difficulty with articulation. So that's typically tongue and palate, but it can also be cerebellum because it can be the vermis. Again, you can get those fasciculations within the palate that prevent you from really articulating words appropriately. You can get dysphonia, so that's typically an issue with regards to the palate and the vocal cords, basically a difficulty with actually enunciating words properly. Dysphagia is different than the dysphagia. That's a difficulty with swallowing. This is a difficulty with essentially comprehension. Or you can get true aphasia. So basically that total loss of speech, or what they're saying doesn't make sense. How you doing today? Sky's blue. Okay, that's a problem. So it can be either that they cannot speak or what they say doesn't make sense. The other thing that you can get is that some patients will only be able to say 1 or 2 words. Yes, like I have one patient, she got to the point where she could only say yes. So everything was yes. But she'd shake her head no. That's hard to do. Everybody try that. Yes, that's hard to do. Yeah. I'm really good at shaking my head no though. So that total loss of speech. When we talk about thought processes, are they logical? Are they relevant? What is the thought content? Make sure that it's appropriate. You know, yes, you had the dirty old man, but is it truly the dirty old man, or has he had a stroke in his frontal lobe? You know, maybe cut that guy a little bit of slack. Their perceptions, their insight and judgment. So what do they think is appropriate? Their impulse control will go a lot along with this. I had one guy, he was a Baptist preacher, and I rolled him over because I was examining his lumbar spine in the ER. And he went to go, and I told him, I said, can you roll away from me? He rolled toward me and promptly grabbed my derriere. And I was like, okay, we're going to have you roll back here. But he had had a prior stroke. Yes, I was examining his lumbar spine, but he had had a prior stroke. So I cut him some slack. So again, remembering judgment. Your judgment is not going to be assessed on every single patient. Hopefully we'll be able to assess it on each other in this room. But truly for your patient who's in a coma, you're not assessing judgment. You know, for your patients who's had major brain injuries, you're not being able to assess judgment. But again, you have to be able to have all those higher cortical functions in place in order to truly assess judgment for patients. So you can sometimes ask them, like, if you were in a crowded movie theater and a fire started, what would you do? They should know that they would pull a fire alarm. Maybe they would be the first one to leave, you know, like crowding over the children and the women, or maybe they would help other people out. But they should know, oh, I pull a fire alarm, I look for a fire extinguisher. Those kinds of things should be normal. We talk about orientation, attention, memory, and new learning ability. When we talk about orientation, the majority of time what you'll see in a chart is A&O times 3, sometimes A&O times 4, right? So alert and orientated times person, place, and time. Sometimes when they add the 4, it's almost always for situation. So you have to be a little bit lenient on your patients, because you might be working at a facility that is essentially a tertiary facility, meaning patients were transported to you for a higher level of care. And so they might know that they were admitted initially to downtown Lee Memorial, but maybe they needed heart stuff, so they were transported to Health Park. So they might know, well, I'm at Lee. Oh, they were at Lee, okay? So you have to be a little bit lenient with that type of issue, because they may not be remembering that they were actually transported once they got to one facility. It's almost better to always just ask, do you know what this place is? Oh, I'm in a hospital. I'm in an office setting. Be more general. Even sometimes I would have to ask patients, is this a church? Are we at the mall? You know, oh no, we're at the hospital. Okay. You know, you have to kind of orientate them back to the simplest answer that you want for them. Are they disorientated? Association occurs with impairment of memory as well as attention span. So if you have the patient who is kind of lapsing in and out of a level of consciousness, they may not remember where they are. They may have been sedated. You know, Versat's a fantastic drug. They may have been sedated for the transfer and therefore not remember where they are. Okay, they may not have been awake, for example. So you typically ask the patient what day it is, what's your name, what day it is. I always ask them what year they were born, because I can really just look at their armband and verify that very easily. You always want information that you can verify very quickly. Plus or minus on asking them who the president is. I've got some interesting answers there. Just depends on if they're currently happy with the president. So that's actually fallen by the wayside in the last couple decades. You can ask them the day of the week. It's almost always hard to ask them the date because especially if you're talking in a patient's room at a hospital, almost always the nurse has written the date on the board. So they just go, what date is it? It's July 22nd. And you're like, you so cheated. Okay, so you need to ask them stuff that you can verify, but stuff that they can't cheat on either. So current events, so ask them the last 4 presidents. Please don't ask me the last 4 presidents. I think I could name them. I think I could. Honestly, that goes to the age of the patient. Some people haven't been alive for the past 4 presidents. So you may want to ask them what's currently going on. If this is conversely a patient that you have, for example, in your office, and you have seen them for a long time, and you notice something's a little bit different, but you knew that the last time you saw them, they were headed to a wedding. Hey, how was Jerry's wedding? And they should be able to recall that. Or, hey, where did you go since the last time I saw you? They should be able to tell you the same story. And you will get the patients, and that's why, like, in the bottom of my dictation, I would always say, like, my last line was, I can't wait, I'm looking forward to seeing the patient back in 6 weeks. At that point, they will have just been on their cruise. So, yes, it sounds nice in the H&P. It's to remind me to ask them about it, mainly for patient relations, but also if they come back and there's a memory issue, I knew where they were and what they should be remembering. Okay, so those are the things that are easy to ask. It's hard to ask that with homeless patients, and we have a large homeless population here, especially with our trauma unit. That's where I would see a lot of these patients. They lose all track of time and conception of time, so it's hard to ask some of those orientation questions to them. You ask them, where do you live? Under the bridge. They literally live under the bridge. And don't bother asking them which bridge, okay? Because that won't get you any further. So your digit span, typically for digit span, what I always go with is serial 7s. And when you talk about, that's what most people use. So most people don't use zip codes or phone numbers. You can always ask the patient what their phone number is. And if they have like a home phone and a cell phone, ask them both because they should know both. And that you can very easily verify on their patient record. But almost always you ask them to count backward in serial 7s from 100. Can we all do that? I practiced this last night. I'm still probably going to get it wrong. 93 is the first one. So anyways, they should be normal with less than 4 errors. Okay, so they should be able to count backwards about 5 times by serial 7s. Okay, 93. What's the next one? 86. 79, 72, 65, 58, 51. Okay. So again, counting backwards or spelling backwards, and almost always the word that everybody uses is the word world. So DLROW. I'm better at that one. Okay. So they almost use that word essentially exclusively to spell backwards, and that actually comes on the mini mental status exam as well. So you want them to repeat the 3 objects that you told them before: a pen, a phone, and a piece of paper. You ask them about recent issues. You ask them about remote things that happened a long time ago. Always an easy cheat sheet is if they are a veteran. A lot of them come in wearing their hat from the war that they were in. They were a World War II veteran. You get some of those still. Korea, Vietnam, and it says right on there what war they were in and what branch they were in and what their rank was. So you just ask them what their rank is because you can look at their hat and verify what they're saying is accurate. Okay, so it's your cheat sheet to make sure that they remember remote history. Birthdays, anniversaries. Again, a lot of that time when you have those patients that you're seeing for years and years on end, you'll actually know when their anniversary is. So you can ask them, hey, when is your anniversary? And you'll know that just because of how long you've known the patient. We talk about information and vocabulary, calculating ability. Even the easiest thing is 2 + 2. Abstract thinking and constructional ability, all that stuff is higher level thinking. So you have to make sure that you actually have an awake patient. It's based on education background. There are some people, and I hate to say it this way, but there are some people who are not stupid. They are simply simple, right? They don't have as high of a level of education because that just wasn't their upbringing. So the concepts that you'll be able to discuss with them, you just have to kind of break down a little bit better, but they typically can understand it once you talk to them at their level. But you can ask them about various words. Define car to me. Okay, define dominant. Remembering that, especially if you ask them about various things that have multiple meanings, like telescope, They might say, oh, what I would use to look at the stars with, or if you have somebody who's in the medical profession, they might be like, well, oh, telescoping, that's what the intestine can do. That's a bad thing. Both are accurate, they're just different, okay? Calculating ability, almost the easiest one to ask them is, if I gave you $1 and something cost 78 cents, how much would you be giving back, okay? But sometimes you can do the easiest calculations. What's 2 plus 2? What's 4 plus 4? And sometimes there's simple addition. We're not like, Stephen Hawking here. We're not doing quantum physics or anything. But they should be able to do simple addition and simple subtraction. The majority of people can do that. Abstract thinking, basically a stitch in time saves 9, right? So if you take care of a problem now, you don't have to deal with all the sequelae later. Don't count your chickens before they're hatched. Those types of things. If they have that higher cognitive function, they should be able to assess that. Now, truly, when we're talking this level of a neurological exam, we're talking essentially a neuropsych eval that's doing this. You're not doing this on every single patient, okay? So you guys don't have to worry about trying to do this on each other. Constructional thinking, you typically ask them to draw something. Typically the easiest, I put this in there because that's the design that's on the mini mental status exam, but the easiest thing to get them to draw is a clock. So you have them draw a face of the clock and they should put the numbers in the right order. And you would be surprised at people that do not put the numbers in the right order because of a organic structural problem within the brain, okay? And there can even be a clock in the room. They can be looking right at it and they still can't draw it right. We talk about cranial nerves, so this is the clean mnemonic. There are several other non-clean mnemonics that are much more fun, but anyways. On old Olympus towering top, a Finn and German viewed some hops. So basically that's your way of remembering the cranial nerves, okay? So this is basically your reminder as to where they all come out. Remember, 2, 3, and 4 are grouped together. 5, 6, 7, and 8 are grouped together. 9, 10, 11, and 12. Oh, not bad. Okay. I love this image. I stole this from a nurse down at Physicians Regional Medical Center because I loved this image in terms of how to remember all the cranial nerves of the face. It kind of, in one big snapshot, lets you understand what controlled what, okay? Isn't that cool? I like it. I know I stole it from her. So we talk about the olfactory nerve, and the olfactory nerve is always, it's underappreciated, let's be honest, okay? So we're assessing sense of smell, so we want to make sure that the nares are patent, number one. So basically, we pinch off one nair and ask them to sniff, and pinch off the other nair and ask them to sniff. The best thing to use, and I picked this up from the AD students who were using it last year, they all come in, because I started like in January with them, doing some of the assessments. They all came in with contact lens cases. I'm like, so people are popping their contacts out before they do it? What are they doing? They had 2 smells, one on each side, okay? They would have coffee grounds in one side and maybe like vanilla bean in the other side or lavender in the other side. Don't use cloves. I mean, cloves you can use, but cloves are what my mother burned in the house to make the house smell good. It's what all my sorority sisters smoked in college. Okay, so don't use cloves. So, you're looking primarily for a frontal lobe issue, remembering that as we age, we get a lot of cerebral atrophy, not necessarily strokes, but a lot of cerebral atrophy, and that the blood supply to the olfactory nerve is a little friable, okay? So it comes up through the ethmoid plate, and it comes off of the external carotid artery. So people will, especially older patients, they'll start to not eat, they'll start to lose weight, and you're wondering, how come you're not eating? And they're like, oh, nothing tastes good. Well, it may not be that nothing tastes good. It may be that they can't smell it, okay? Another prime example, I had a lady, I wish I would have put her MRI image up here because I still have it. She had a tumor the size of a softball in her frontal lobe. So she wasn't eating because, mind you, she wasn't losing weight either, but she wasn't eating because she couldn't smell anything. So we went to go take the tumor out. Actually, we had to cut one olfactory nerve completely because it was just shredded anyways. Unfortunately, the other one got essentially partially shredded with taking it out because the tumor was literally like 7 or 8 centimeters in size. She could smell fine right afterwards. So the olfactory nerve can actually take a licking and keep on ticking. You can basically go down to like a half of one and still do fine. But you've got to make sure that you assess it. So they have to be able to smell. A lot of the reasons why some people don't eat is because they can't smell appropriately. So they should be able to close one side of the nair, smell. They should identify the smell. Don't use the same smell on the other nair. That's why you have a contact case. Use the 2 different scents. We talk about the optic nerve. So again, we basically start in the Occipital cortex, we move all the way forward. We're going to end at the retina, okay? So we're assessing vision. We have two ways of assessing vision. We can use the Snell eye chart, which is the one that you stand at your eye doctor and you're looking far away and you're supposed to read the lowest line down. And the other one is either you all have it on a little cheat sheet card or it's on the back of your Maxwell, right? So you use that one. That is essentially the Rosenbaum eye chart, and that's for your near vision. You hold it about 14 inches and they should read the lowest line possible. Always noting that if you have a patient with corneal abrasion, okay, or they have something in their eye and they're doing this, that's probably a good look for me, right? Because their eyes hurt so badly, that is not an appropriate visual acuity test. You need to numb the eye to get an appropriate visual acuity test. They're squinting because of pain, you cannot assess them, okay? So you want to make sure you perform it with and without glasses. Then you want to do the ophthalmoscope exam. So you check for the optic disc, the retinal vessels, and the macula. In all honesty, are you going to see that in somebody with bright lights on? No, right? Because the pupil is going to be too small. Typically, you need a dilated pupil, a dark room. That's why when you go to the eye doctor, for all of us that go to the eye doctor, you know, like every other year he dilates you at least, right? Because he actually has to get a good look at the vasculature and the posterior aspect of the eye and get a good look at the macula and the retina. And then we do visual fields by confrontation. So visual fields by confrontation are basically, you come at you, right? Because we're looking at the peripheral vision. So you have the person look straight ahead, and you can wiggle your fingers and tell me when you can see him. I can see him here. Tell me when you can see him. I can see him right there, okay? Because remember, when we talk about our eyes, the eye nerves come forward. And remember, at the optic chiasm, half of the eye nerves cross and half don't. So if we have an issue on the back posterior right side of the visual cortex, what is going to, if that's where our problem is, what that's going to reflect on our visual exam, we are going to lose the temporal aspect of the right eye and the medial aspect, the nasal aspect of the left, right? Because the nasal aspects cross and the temporal aspects go on and stay straight. So when you're doing visual field by confrontation, you can notice a visual field deficit, and it should directly point you in the posterior aspect in that visual cortex to where the problem is going to be. You're either going to lose part, if you're talking visual cortex, you're either going to lose half on both eyes, half on the other. Conversely, when we talk about the optic chiasm, we're talking about losing posterior, so we're going to be able to see down the center, but we're going to lose the posterior vision, so those patients actually get tunnel vision, okay? When we talk about the oculomotor nerve, always think about this like as a Roman column. The whole point, one of the big points, oculomotor nerve does a lot, but one of the big points is it's supposed to keep your eye open. So the easiest remembrance of that is just a Roman column that it's supposed to hold your eyelid up, okay? So when you have ptosis or you have a weakness on that side, it is because that cranial nerve is not opening the eye, keeping the eye open appropriately, okay? The other thing it does is it does lots in terms of ocular motor function. Basically, it does everything except superior oblique and lateral rectus. Superior oblique is 4, lateral rectus is 6. That's all 4 and 6 do. They don't do a whole lot. Okay, they're like there for the party. 3 does all the work. It also helps with pupillary constriction and accommodation. So basically, when you assess for pupillary response and accommodation, you are also partially assessing cranial nerve 2. So that's basically accommodation, okay? So your pupil should constrict, and you should have consensual constriction of the contralateral pupil. That's what you're trying to look for when you shine the light in someone's eye. So you're looking at direct. If I shine the light in your eye directly, does that pupil constrict? And then when I shine it in that eye again, does the other pupil constrict? Because it should. Okay, you should have that automatic response on both sides. If you don't, one of the big conditions we start looking for is white matter disease within the brain. MS is a big one. When we talk about, again, about the right eye, so the right eye, this is a picture of the right eye. The right eye does a lot. Basically, it just doesn't, this is 4, here's 6. Everything else is covered by 3. So we're talking about extraocular movements, and that's where follow my finger with your eyes, and you look laterally, and you look north. Sometimes I'll actually have you go diagonals, because they're really trying to assess 4 and 6 a little bit better. That's what you're looking for in terms of extraocular movements of the eye. Remembering that that can be on a continuum, because those nerves, even though they're exiting out through the brainstem, they're transversing all the way anterior to actually innervate the muscles in the, of the eye. Okay, so you can have a lesion at multiple sites that could potentially cause an issue with the cranial nerve. We talk about the trochlear nerve. The trochlear nerve is the longest of all of the cranial nerves. It transverses the largest distance because it crosses, okay? So it's responsible only for the superior oblique. That's all it does. Comes to the party and does superior oblique. Cranial nerve 6 comes to the party, does lateral rectus. That's it, okay? So typically what you're looking for is some people will have, I had one guy, he, not enough time for all these stories. Okay, but anyways, I had one guy, have I told you this guy that was using Cialis and Viagra? Hold the phone, right? And I looked at his wife. It wasn't her. Oh, sorry, that's a little low blow this early in the morning. But if you saw her, you'd know what I mean. I was like, there's no freaking way. He's using Cialis and Viagra every day, brainstem stroke, and my boss is like, what's going on with him? I'm like, oh, he's having a brainstem stroke. What cranial nerves are involved? I go, what cranial nerves aren't involved? He had 3 and 4 on one eye and 6 and 3 on the other. And literally, he was like, looked like a fish, all googly eyed, you know? So, he got better though. I'm inappropriate in the morning, sorry guys. All right, so trigeminal nerve. Trigeminal nerve is big, right? So it covers all motor and sensory. So it covers the 3 different sensory distributions of the face: forehead, cheek, and lower face. Trigeminal neuralgia, which is the pain that occurs from irritation of the trigeminal nerve, is by definition known as the worst pain known to man because it is so horribly painful. So it has the ophthalmic, which is essentially the forehead, the maxillary, and the mandibular branch. But it also is responsible for the corneal reflex, all the sensory functions, all the motor functions. So a lot of the motor functions of mastication, like how we actually chew our breakfast, happens with the trigeminal nerve. Remember when I talked about the trigeminal nerve being obese? It is obese. It is a fat nerve as it comes forward because right from the brainstem as it comes forward, it already has the 3 branches coming forward. But at one point, they're essentially hubbed in one little limb, so to speak, before they essentially trifurcate as they move forward. So this little kid's cute. But anyways, temporalis, so how we clench our teeth, muscle of mastication, so being able to move your teeth from side to side, all of that occurs secondary to the trigeminal nerve. So when we check sensation, we want to assess all 3 distributions, right? You want to touch the patient's face if they'll let you. Patients with trigeminal neuralgia will not let you. But be able to assess all of that. Ask them to bite down and clench their teeth. They should be able to hold and clench their teeth together. You should be able to palpate the masseter muscle, temporalis muscle. You should be able to palpate that as well. That should be right on the lateral aspect. Again, so you're just using typically a cotton swab just to assess all 3 distributions. Kind of get the forehead, get the cheek, get the chin. You get those 3, you're good to go. The corneal reflex, typically you don't do a whole lot of corneal reflex on people. Why? Because we don't want to cause corneal abrasions. Okay, so be very, very gentle when you test this on each other. I don't want everybody walking in like this one day. You know? So you ask the patient to look to the contralateral side, and you're going to actually put a wisp of cotton on the cornea, and they should blink secondary to this. This is why we don't have flies randomly going into our eyeballs all the time, right? Because we actually have an intact blink reflex. So when you do that, you're actually assessing cranial nerve 5, both your sensory input, as well as cranial nerve 7, your motor output, to actually be able to blink to that response. Okay, so yes, in theory, you would test. Most patients have a pretty good motor output for cranial nerve 7 that basically even if you just touch their eyelashes, girls, we kind of get used to it because we put mascara on. But most, you actually just even touch their eyelashes, they'll blink a little bit, okay? Everybody's touching their eyelashes. Cranial nerve 7, so facial muscles and taste, anterior 2/3 of the tongue, external aspect of the ear, small component there. Basically, always think of this, just as you think of a Roman column, think of a fish hook. Okay, so it's going to hook the eye down, so it is what allows you to close your eye. You should ask them to bare their teeth, smile. So what I always ask patients to do was, give me a big smile, puff out your cheeks like a fish, stick out your tongue, and wrinkle your forehead. Okay, and when they puff out their cheeks like a fish, you push on them. You push on their cheeks, and they should be able to hold it, without like having decreased muscle strength there. So those were always kind of the easy things, and also to make sure that you have symmetry to the face. Okay. So you should be able to close your eyes and squeeze your eyes. Don't let me open them, and you'll pull them open. If you can pull them open on one side, they have a cranial nerve 7 defect on that side. Okay, they should be able to hold their eyes closed. So cranial nerve 7 is interesting because, again, part of it crosses. So when we talk about, for example, Bell's palsy versus somebody who's had a stroke, somebody who has had Bell's palsy is this classic picture here, because where her deficit is, where the irritation to cranial nerve 7 is actually in the essentially peripheral aspect of the nerve, right? So it's after part of the nerve has crossed. So the forehead innervation is not spared. Therefore, they have a drop of the forehead on that side, okay? Versus somebody who has had a stroke, and they actually will typically have on the side where they have the lack of a labial fold or the droop of the lower aspect of the face, they can typically raise their forehead, okay? So that's kind of, if you have somebody and you immediately walk in and they're like, oh my God, I woke up this morning and I'm so worried because I think I had a stroke. Raise your eyebrows. If they can't raise their eyebrow on that side, Bell's palsy. I mean, yes, you have to CAT scan them and all that kind of fun stuff, but in theory, if the forehead's taken out, it is a peripheral nerve issue because of where cranial nerve 7 is. So that's how you ask them to raise their eyebrows, and you want to make sure, despite the Botox, that they can actually raise their eyebrows symmetrically, okay? I say that a little tongue-in-cheek. All right, so vestibular cochlear, so this is our hearing, our balance, our awareness of position in space. So this is how we're going to assess whether they have a bone conduction issue in terms of hearing loss or an air conduction issue. This is not somebody that you have to talk to very loudly to wake them up with repetitive stimuli because they're lethargic. This is somebody who structurally has an issue. So we have both the Rene test, which compares air conduction to bone conduction, and the Weber test. So basically, one easy way just to assess is you cover one ear, you go to the other side, and you typically will say, just like you do when you're checking the pulmonary exam, you say 99, and they should be able to say 99. They should know what you're saying back, okay? They should be able to hear because you're covering that contralateral ear. When we talk about the Rene test, so we use our tuning fork. Everybody bought a tuning fork, right? So you slap it on the side of a desk, and you basically are going to put it on the mastoid, and you're going to look for that bone conduction. And once the bone conduction is lost, you should be able to put it in front of their ear, and they should still be able to hear. Air conduction should be greater than bone conduction, and that is essentially normal for a Rene test, okay? When we talk about a Weber test, now we want to see if the hearing loss is lateralizing. So is it bad in one ear versus the other? So we're going to hit the tuning fork again. We're going to place it on top of their head, and at which side are they actually hearing the tuning fork greater? They should hear it equally on both sides, right? It should be transmitted equally if we actually have it in the center of the head. I mean, don't put it over here, you know what I mean, or over here. Put it like right in the middle. So it should be normal if you're putting it right in the center of their head. We talk about glossopharyngeal, so again, sensation to the pharynx, the posterior aspect of the tongue, as well as tympanic membrane. So sensory fibers of the parotid gland. If you're like me and all you have to do is hear about chocolate, and all of a sudden your mouth starts to water, glossopharyngeal nerves working overtime. So sensory function, this is your gag reflex. Please don't gag each other unless you want to get vomited on, which that would be okay. So posterior third of the tongue. But basically, you ask that you can stick a little tongue depressor in, and kind of if you go back even just a little bit further, they'll gag a little bit. Again, there we're assessing both the sensory input as well as the motor output, right? So the vagus nerve is what's going to actually cause us to gag because we got the appropriate afferent input from the glossopharyngeal nerve. We ask the patient to open their mouth and say ah, because we want to see the symmetrical aspect of their uvula, make sure it's midline, and the posterior aspect of the mouth, and we also want to look at the soft palate. So you want to make sure that you aren't seeing fasciculations, that you should see appropriate rise and fall. Okay, it should not be moving 400 times a minute. That's going to definitely go to why they're then having their speech issues. Okay. So again, and it should be, you know, if it's abnormal, it's actually going to deviate toward the normal side because of the pull of the stronger muscles. This is different than your tongue, okay? So we'll talk about tongue in a minute. So when we talk about the vagus nerve, so again, parasympathetic innervation of a lot of the viscera, abdomen, our heart, right? We talk about the vagus nerve big time with regards to the heart. You only have to do a carotid one time and kind of futz, so to speak, with the vagus nerve, little bradycardia, okay? It comes back. Motor function to the pharynx and the larynx as well. You get this exam basically is done while you're examining the glossopharyngeal nerve. So while you're asking and you're kind of gagging them a little bit, that's where you're basically going to get your examination. You don't have to specifically examine cranial nerve 10 because there really is no way. Because the majority of where it transverses is down into the abdominal area and into the cardiac area. Okay. So you want to listen to the tone and volume of their voice, and again, during any problems with articulation of their speech. So when you're assessing it eventually for your clinical exam, essentially while you're assessing 9, you're saying, hey, I'm assessing 10 as well. Okay. The spinal accessories to the sternocleidomastoid and trapezius. So basically, you ask people to shrug their shoulders. They should be able to keep their shoulders up, and you shouldn't be able to push them down. Okay. Very unusual to get an isolated cranial nerve 11 injury. Honestly, I've never seen one. In theory, I guess it could happen. But really, if you're starting to see 9 and 10, you got to start looking at 11 primarily because of where they all originate in the brainstem. So turn their head to the side, and they have to go against resistance. Basically, you put your chin to the side, and they should be able to resist against your hand, pushing them back to the midline. And then always ask them to shrug their shoulders. They should be able to hold them up against you pushing down. And I mean, you don't have to like throw all your weight behind it. Just push down, okay? Hypoglossal, so these are the motor fibers that allow you to stick your tongue out. So you want to have them stick their tongue out and kind of rest it and put their teeth. You want to make sure that they don't have gesticulations to their tongue, but you want to make sure that the tongue is midline. It should stick out straight. Remember that the tongue muscles push, they don't pull, which is different when we talk about the uvula, right? We talk about glossopharyngeal. So we talk about the hypoglossal. Basically, if we have a defect on one side, it's going to push toward the defected side, okay? Because we push, we don't pull. So this dude killed the pattern. That's good timing. So this dude, the tongue deviates toward the weak side, okay? Because the muscles push away. So one area where we always got some, not always, but if you had a risk for hypoglossal injury was in the carotid artery surgery because the hypoglossal nerve actually breaks down that low. It came right kind of at the high bifurcation of the internal carotid. You can almost always see it if you went looking for it. And if you injured it, even if you stretched it a little bit, you would get a tongue that would deviate because of you damaged the side that you worked on. So basically, it always looks like they were licking their incision. Did I just say that out loud? Yeah. So if their incision was on this side and you damaged, incision's on the right, you damaged the right hypoglossal, they would push toward the surgical side. Okay, so think of it that way. All right, so this is just a lovely review of all your cranial nerves, okay? So olfactory is smell, optic is vision, ocular motor is going to be your eye movements. Remember, everything 4 and 6 just kind of come to the party, but they don't do a whole lot. 3 really takes over most of the work. Trigeminal nerve is your big fat nerve that accomplishes a lot in terms of sensation as well as motor function. If you like to not only feel your face, but you like to eat pizza, then you should have an appreciation for your trigeminal nerve. Facial nerve is going to be facial expression, so puffing out your cheeks. It is going to be part of taste as well, but it's primarily puffing out your cheeks. Give me a big smile, raise your eyebrows. Okay, so when we think about stroke or Bell's palsy, we always are looking at the facial nerve. That is why Bell's palsy patients don't hurt, because they've affected the facial nerve. They've affected the motor component, not the sensory component of the face, right? Vestibular cochlear, so our hearing, our equilibrium. Glossopharyngeal, basically part of the sensation within the pharynx and the ears, but also helps to elevate the palate. So we're really looking at the uvula when we look at the glossopharyngeal. Vagus, we're kind of assessing as we do assessment of cranial nerve 9, because you can't really assess heart rate. I mean, we don't want to necessarily make someone bradycardic and just see if they happen to come out of it. That would not be a good neurological assessment. Spinal accessory are going to be our head movements, so being able to resist, basically stabilizing your head on your body is almost always cranial nerve 11. And then your tongue movements are going to be hypoglossal. Okay, so how it essentially moves within your mouth, but mainly being able to stick it out straight at somebody who passed you on the road and wasn't nice. Any questions? I know that was a lot, but I finished on time. All right, so next week you have your quiz. Next week, apparently we have PD lab for neuro. I'll check my schedule, I promise. And next week we're also doing the second aspect of the neurological exam. Yes?